Thank you, Dr. Goisim, for the kind introduction. It is a great honor for me to be giving the Prof. Bosco Memorial Lecture. Prof. John Bosco was a leading figure in the field of hematology in Malaysia. He was a professor of immunology and clinical hematology at University Malaya and our very first president of the Malaysian Society of Hematology. Sadly, he passed away at a young age of 54 while playing a game of tennis. He has inspired many, and his legacy will live on with us. This lecture is dedicated in his memory. The COVID-19 pandemic has brought on much hardship and misery to mankind. We are now forced to live in a new norm. The political crisis in our country is not helping either. We are at present in a state of emergency. The economy has taken a slump and we are in deep debt. Due to the many lockdowns, the blood supply is running low. But don't panic. In the West, they stock up on toilet rolls. However, here in Malaysia, we are more worried about the other end. So please keep calm and use common sense, which brings me to my talk, Saving Dollars with Sense. Do you know that 70,000 bags of blood are transfused every year in Malaysia? That is equal to 2,000 bags of blood per day. And most of these transfusions are inappropriate, as shown by many studies in the range between 40 to 60%. In a review by Prof. Shander, looking at close to 500 publications, he found that only 12% of transfusions are appropriate. Most of them are of no benefit and some may cause harm. So what could be the reason for this? Is it because blood is so freely available and at no cost because they are voluntarily donated? Let us look at the real cost of blood transfusion, beginning from its acquisition, to the screening of viruses, to its storage, to its administration, which includes blood grouping and cross-matching, hospital monitoring, and the treatment of adverse events. Adding all this up together, 1 unit of packed red cells costs between $700 to $1,000 based on this study by Hoffman. So what is the cost of 1 unit of packed red cells in Malaysia? According to the full paying patient list, 1 bag of blood costs 120 ringgit, which is way below the real cost of blood transfusion if you take into account its acquisition to the treatment of adverse events. So if I put the cost of 1 bag of blood to be 500 ringgit, which is still a gross underestimation, then for 2,000 bags of blood transfused per day, if you do your math, that will come up to 1 million ringgit per day spent on blood transfusion alone. That is a lot of money. And that does not take into account the management of adverse transfusion reactions and hospitalization costs, as well as litigation costs due to wrong blood or ABO incompatible blood transfused. This data is taken from the National Hemovigilance Study conducted by the National Blood Centre, looking at adverse events between 2016 to 2019 reported from 22 hospitals across the country. Adverse transfusion reactions account for the highest number of adverse events at more than 4,000 every year. Incorrect blood component transfused was highest in 2019 at 52, and half of it was due to wrong blood transfused. Every year, more than 200 near misses were reported. Incident events are due to transcription errors. All in all, I would think that the numbers of adverse events are underreported, and I encourage all hospitals to contribute to this data on hemovigilance. This graph shows you the frequency of blood components and its implication in adverse transfusion reactions. Packed red blood cells, being the most frequent blood component transfused, account for the highest number of adverse transfusion reactions at more than 3,000. Hence, if we reduce the number of packed red blood cells transfused, then we can reduce the number of adverse transfusion reactions. So if we reduce our transfusion rates by just 5%, then we will transfuse less 100 bags of blood per day. And taking 1 unit of blood to be 500 ringgit, and if you do your math again, we can save 50,000 ringgit a day or 1.5 million ringgit per month, which comes up to 18 million ringgit per year. That is a lot of cost savings. And even after paying the emolument for our bloated cabinet, which is 1 million ringgit per month, we are still able to save 500,000 ringgit per month or 6 million ringgit a year. And how do we do this? By practicing patient blood management, or PBM for short. What is patient blood management? It is a timely application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration, optimize hemostasis, and minimize blood loss in an effort to improve patient outcome. In PBM, the patient's own blood takes priority. We need to change our transfusion practice from product focus, which is the blood, to patient focus, how we can make the patient his own blood bank. The concept of PBM is not new. The World Health Organization has officially been urging member states to implement PBM since 2010. The aims of PBM are to optimize clinical outcomes and improve patient safety by avoiding unnecessary exposure to blood and blood components. There are many modifiable risks that contribute to transfusion overuse. They are the presence of correctable anemia, excessive surgical blood loss, excessive blood loss due to unnecessary blood taking, and uninformed and poor transfusion practice. I'll take you through this one by one. The presence of correctable anemia. Do you know that 1/3 of the world's population are anemic? And the leading cause of anemia is iron deficiency, followed by anemia of chronic disease or inflammation due to underlying diabetes mellitus, chronic kidney disease, and congestive cardiac failure. And I'm sure you're aware that Malaysia tops the list of countries in Asia to have the most number of people with diabetes mellitus. And with diabetes comes chronic kidney disease, and with chronic kidney disease come anemia of chronic disease or inflammation. So anemia of chronic disease is a major health problem. In a large study by Musalam, looking at over 200,000 patients undergoing major non-cardiac surgery, he found that 1 in 3 are anemic prior to surgery. In another study looking at 200 patients who were anemic undergoing total hip replacement, it was found that iron deficiency is the most common cause of preoperative anemia at 60%. In the same study by Musalam, he found that preoperative anemia increases the need for perioperative blood transfusion, even for mild anemia. He also found that preoperative anemia negatively impacts postoperative mortality at close to 5% for any anemia. This is the only randomized controlled study looking at IV iron in perioperative blood management. Patients who were found to be iron deficient prior to elective major abdominal or gynecological surgery were randomized into the intervention arm with IV ferric carboxymaltose at 1 gram up to 1 gram 4 to 21 days prior to surgery, and 0.5 milligram for 1 ml recorded blood loss 2 days after surgery, compared to the usual care arm. Either they receive no treatment, continued observations, oral iron, or even allogenic blood transfusions, and they were followed up for 4 weeks post-surgery. The results show that the IV iron arm had a 60% reduction in transfusion rates, as well as a reduction in hospital stay by up to 3 days. So that would be a lot of cost savings. I have mentioned that iron deficiency and anemia of chronic disease are the leading causes of anemia. In our practice, we use a lot of IV iron and erythropoietin. Here is a 65-year-old gentleman receiving his IV iron infusion in preparation for his prostate surgery. His pre-op hemoglobin was only 5 grams per deciliter, and we managed to bring his hemoglobin up to 13 grams prior to surgery with just IV iron infusion alone. Depending on the urgency of surgery and the presence of chronic disease, we will add on erythropoietin. The second modifiable risk is excessive surgical blood loss. So, if one needs to anticipate bleeding, especially in major surgeries. So, if a patient is on antiplatelets or anticoagulants, they are advised when to stop these medications prior to surgery. Meticulous surgical techniques are also very important. If you're dealing with a large vascular tumor, then embolizing the feeding artery can reduce blood loss during surgery. I would like to emphasize that prompt arrest of bleeding is very important and that watch and wait and blood transfusion will not work. As illustrated in this case here, this is a CT scan pelvis showing a bleeder from the branch of the external iliac artery following a bone marrow aspiration and trephine biopsy. The decision was taken to watch and wait, transfuse him with blood, and by the time we brought him to the theatre, he had so much bleeding that we lost him from uncontrolled bleeding and disseminated intravascular coagulation. The third modifiable risk is excessive blood loss due to unnecessary blood taking. Do you know that adult ICU patients lose between 300 to 600 ml of blood per week to diagnostic testing? And that more than 70% develop anemia by their second day in ICU, and ultimately 50% will be transfused. Hence, we need to limit blood taking by avoiding unnecessary blood tests, such as routine pre-op PT and APTT, because PT and APT will not predict bleeding. We need to consider using pediatric collection tubes in our adult patients, especially in ICU, because we can reduce the blood volume loss due to blood taking. From the observations that there were a lot of unnecessary pre-op tests ordered for minor surgeries, our center, Hospital Ampang, set out to look at the compliance of preoperative tests in elective surgery. The objective of our study was to estimate the extent of inappropriate pre-op tests, especially in minor elective surgeries, and to identify factors associated with inappropriate pre-op tests. We looked at all elective surgeries between January and June 2016. All pre-op tests were identified, tabulated, and graded as appropriate and inappropriate tests. The appropriateness of test was defined based on the Malaysian CPG recommendations on pre-anesthetic assessment and the NICE guideline. Systemic condition was graded using American Society of Anesthesiologists ASA guideline into normal, mild, severe, or severe with constant threat to life. The proportion and cost of inappropriate tests was calculated. This is a NICE guideline showing you the recommended tests before an elective surgery. Here on the column on the left is the ASA grading patient into normal, mild systemic disease, severe systemic disease, and severe systemic disease with constant threat to life. The top here is the complexity of surgery divided into minor, intermediate, and major surgeries. And here in the middle are the recommended tests for each category. So the more severe the systemic disease and the more complex the surgery, and it's major surgery, then the number of recommended tests are more. But what I would like to draw your attention to is the box in purple, the test of hemostasis here in the severe systemic group and the intermediate and major surgery groups. The tests of hemostasis are PT and APTT, and the recommendation here is hemostasis tests are only recommended for people with chronic liver disease. And here we are doing routine pre-op PT and APTT indiscriminately for almost all procedures. Our results show that there were a total of 380 patients involving 383 elective surgeries, of which 220 were minor, 101 were intermediate, and 62 were major, bringing to a total of 2,296 pre-op tests. This is the table showing you the top 5 most ordered pre-op tests for minor surgeries, intermediate, and major surgeries based on its ranking. And as you can see here, across these 3 surgical groups, the top 5 most ordered tests were full blood count, renal function, PT-APTT, antibody screening, and blood grouping. The proportion of inappropriate tests was highest in the minor surgery group at 88%, and antibody screen and blood grouping tops the list. In the major surgery group, PT and APTT account for the most number of inappropriate tests. From statistical analysis, inappropriate pre-op tests were significantly more frequent in minor surgery, children less than 15 years, female, patients with ASA grade 1 and 2, no AKI risk, and less than 2 concurrent illnesses. The cost burden of inappropriate tests were calculated in this 6 months period, and In minor surgery, inappropriate tests came up to 10,000 ringgit, for intermediate surgery 5,000 ringgit, and for major surgery close to 1,000 ringgit. If we follow guidelines and not send inappropriate tests, we could save a lot of money if all hospitals across the country practice and follow the guidelines. So the study concluded that pre-op tests were ordered without considering its needs based on type of surgery and patient's condition, especially in minor elective surgeries. A mechanism should be put in place to ensure appropriate utilization of pre-op tests. Uninformed and poor transfusion practice, the fourth modifiable risk. I am sure you're all aware of the practice of trying to correct a number, such as transfusing 4 packed red blood cells to correct a hemoglobin of 6 because you want to bring it up to 10 grams per deciliter, instead of using a single unit policy if really needed, or FFP transfusion to try to correct a prolonged PT and APTT. FFP transfusion before wound debridement to reduce bleeding, and red blood cell transfusion for wound healing. These are all poor transfusion practices. Let me illustrate with you a case of LAHPS, or Lupus Anticoagulant Hypoprotrombinemia syndrome. This is an 11-year-old boy who complained of fever for 5 days and easy bruising for 3 days. His hemoglobin was 13.2 and his platelet was 89. His PT and APTT was markedly prolonged. PT was 21.8 seconds and APTT was 104.5 seconds. So he was admitted into hospital and bloods were taken from him almost daily for PT and APTT and full blood count. The prolonged PT and APTT were not investigated, but instead, almost daily FFP was transfused in this child. And as you can see here, despite transfusing FFP, the PT and APTT was not corrected. This was due to the presence of the lupus anticoagulant. So this went on for almost a month, and because of so much blood taking, the child became anemic and had to be transfused with packed red blood cells. So in total, this child was transfused with 22 units of fresh frozen plasma, 3 units of cryoprecipitate, 2 units of platelets, and 2 units of packed red blood cells. He developed urticaria from some of the FFP transfusions and had to be admitted to ICU for transfusion-related acute lung injury or TRALI. Imagine if one of these bags of blood is tainted with HIV. This is poor transfusion practice, a practice that has to stop. One needs to treat the patient and not the number. And if you do your math again, taking 1 bag of blood or blood component to be 500 ringgit, then it will come up to close to 15,000 ringgit of unnecessary blood and blood transfusion used in this child. And that does not account the cost of hospitalization and his treatment is in ICU for his TRALI. So there are so much wastage of resources. We need to use our resources wisely because these are all our hard-earned taxpayers' money. So please use our resources wisely. So in summary, I'd like to conclude that 1 in 3 patients are anemic preoperatively, and that iron deficiency is the most common cause of anemia. There is a 5% mortality with blood transfusion, and IV iron is safe and effective. There is a 60% reduction of transfusions with IV iron prior to surgery, and PT and APTT does not predict bleeding. So my take-home message to you is please change your transfusion practice from product focus to patient focus, in line with our theme for MSH 2021, Shifting Paradigms, Changing Practices. We need to practice the 3 pillars of patient blood management, which are optimizing hemostasis, minimizing blood loss, and optimizing tolerance to anemia. By practicing PBM, not only are we saving dollars, we are also saving lives. Before I end my presentation, I'd like to encourage you to come join our Society of Patient Blood Management. please visit our website at pbmshare.com. And also please come and visit us at our virtual booths during these 3 days of meeting and have a chat with us and download all the pamphlets and guide to PBM. And thank you for listening. I would like to leave you with this last slide and a moment of silence.